Osteoporosis diagnosis and risk stratification using DEXA T-score and FRAX. Osteoporosis affects an estimated 10% of men and 20% of women over age 50, accounting for greater than 300,000 fragility fractures annually in the United States. The disease results from an imbalance between osteoclast-mediated bone resorption and osteoblast-mediated bone formation, driven by hormonal, genetic, and inflammatory pathways. Dual-energy X-ray absorptiometry, DEXA, derived T-scores and the WHO-endorsed FRAX algorithm are the cornerstone of case identification and therapeutic decision-making. First-line anti-resorptive therapy, e.g., alendronate 70 mg weekly, combined with calcium 200 mg per day and vitamin D 800 to 1000 IU/day reduces vertebral fracture risk by 45%, RR 0.55, and hip fracture risk by 30%, RR 0.70, over 3 years. Key points. Note, osteoporosis is defined by a DEXA T-score less than or equal to 2.5 at the lumbar spine, total hip, or femoral neck, ICD-10 M80 M82. A 10-year major osteoporotic fracture probability greater than or equal to 20% or hip fracture probability greater than or equal to 3% on FRAX classifies a patient as high risk per WHO and NICE guidelines. Calcium 200 mg per day is almost equal to 500 mg elemental calcium from diet plus 700 mg from supplements, and vitamin D 800 to 1000 IU/day raise serum 25OH vitamin D to greater than or equal to 30 nanograms per milliliter in greater than 90% of patients. Alendronate 70 mg orally once weekly for greater than or equal to 3 years reduces vertebral fracture incidence by 45%, NNT is almost equal to 20, and hip fracture incidence by 30%, NNT is almost equal to 30. Zoledronic acid 5 mg for once yearly improves hip BMD by 4.5% and reduces hip fracture risk by 41%, RR 0.59, in postmenopausal women. Denosumab 60 mg SC every 6 months lowers serum C-telepeptide, CTX, by 70% within 3 months and reduces vertebral fracture risk by 68%, RR 0.32. Teriparatide 20 GSC daily for 18 to 24 months increases lumbar spine BMD by 9% and reduces new vertebral fractures by 65%, RR 0.35. Romosozumab 210 mg SC monthly for 12 months yields a 12% increase in total hip BMD and a 38% reduction in vertebral fractures, RR 0.62. FRAX incorporates age, sex, BMI, prior fracture, glucocorticoid use, rheumatoid arthritis, secondary osteoporosis, smoking, alcohol greater than or equal to 3 drinks/day, and femoral neck BMD. Each factor contributes a weighted point value. In patients with eGFR less than 30 ml/min/1.73 square meter, denosumab is preferred over bisphosphonates, but calcium and vitamin D must be monitored for hypocalcemia. Incidence is almost equal to 5%. The 2023 NICE guideline NG38 recommends repeat DEXA at 2 years for patients on anti-resorptives with T-score improvement less than 0.5 SD, and at 5 years for those with stable BMD. Vertebral fracture assessment, VFA, by DEXA detects greater than or equal to 80% of moderate to severe vertebral fractures missed on plain radiography. Overview and epidemiology. Osteoporosis is a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration, leading to increased fragility. The International Classification of Diseases, 10th revision, ICD-10, codes M80, osteoporosis with pathological fracture, M81, osteoporosis without current fracture, and M82, osteoporosis, unspecified, are used for billing and epidemiologic tracking. In 2022, the global prevalence of osteoporosis in adults greater than or equal to 50 years was 18%, is almost equal to 200 million individuals, with the highest rates in North America, 22%, and Europe, 20%, and lower rates in East Asia, 12%. In the United States, 10.3% of men and 20.3% of women greater than or equal to 50 years have osteoporosis, translating to is almost equal to 10 million cases in men and is almost equal to 10 million in women, CDC, 2022. The annual economic burden of osteoporotic fractures in the U.S. was $19.5 billion in 2022, of which $13.2 billion were direct medical costs and $6.3 billion were indirect. Productivity loss, long-term care. Non-modifiable risk factors include age, RR is almost equal to 2.5 per decade after 50, female sex, RR is almost equal to 1.8, Caucasian or Asian ancestry, RR is almost equal to 1.5 versus African ancestry, and family history of hip fracture, RR is almost equal to 2.0. Modifiable risk factors with quantified relative risks are current smoking, RR equals 1.5, daily alcohol intake greater than or equal to 3 drinks, RR equals 1.4, glucocorticoid exposure greater than or equal to 5 mg prednisone equivalent daily for greater than or equal to 3 months, RR equals 2.0, low body mass index, BMI less than 20 kg per square meter, RR equals 1.8, and secondary causes such as hyperparathyroidism, RR equals 2.2, or rheumatoid arthritis, RR equals 1.6. The cumulative incidence of a first fragility fracture after age 65 is 12% in women and 5% in men over a 5-year period, NANS, 2021. Pathophysiology. Bone remodeling is a tightly regulated process involving osteoclast-mediated resorption and osteoblast-mediated formation. At the molecular level, the receptor activator of nuclear factor kappa B ligand, RANKL, binds rank on osteoclast precursors, promoting differentiation, osteoprotegerin, OPG, acts as a decoy receptor, inhibiting this interaction. Postmenopausal estrogen deficiency upregulates RANKL expression, 30% in serum, and downregulates OPG, 25%, shifting the balance toward net bone loss. The WNT/beta-catenin pathway, modulated by sclerostin, encoded by SOST, is another critical regulator. Sclerostin inhibition, e.g., romosozumab, leads to a 12% increase in total hip BMD over 12 months in phase 3 trials. Genetic contributions account for is almost equal to 70% of peak bone mass variance. Polymorphisms in the LRP5 gene, e.g., V667M, confer a 1.4-fold increased fracture risk, while the COL1A1SP1 binding site variant, GT, raises risk by 1.3-fold. Epigenetic modifications, such as hypermethylation of the SOST promoter, have been linked to reduced sclerostin expression and higher BMD in animal models. Clinical presentation. The classic presentation of osteoporosis is a fragility fracture occurring from a fall from standing height or less. In a cohort of 5,000 postmenopausal women, 68% of vertebral fractures were identified incidentally on imaging performed for back pain, while 32% presented with acute back pain and height loss greater than or equal to 2 centimeters, hip fractures present with sudden groin pain, inability to bear weight, and a shortened, externally rotated limb. They account for 15% of all osteoporotic fractures but 60% of fracture-related mortality. Wrist, distal radius, fractures are the most common peripheral fracture, comprising 35% of fragility fractures. Atypical presentations include chronic low-grade back pain without obvious vertebral deformity, seen in 12% of patients with grade 1 vertebral compression, and in diabetics, a higher prevalence of silent vertebral fractures, up to 20% prevalence on VFA despite no symptoms. Immunocompromised patients, e.g., HIV positive on protease inhibitors, have a 1.7-fold increased risk of hip fracture. Diagnosis. 1. Initial risk assessment, obtain a detailed history, prior fragility fracture, glucocorticoid use, secondary causes, and calculate FRAX using the online tool or integrated EMR calculator. 2. Laboratory workup, order, serum calcium 8.5 to 10.2 mg/dl, albumin 3.5 to 5.0 g/dl, 25 OH vitamin D, 30 to 100 nanograms per milliliter, phosphate, 2.5 to 4.5 mg/dl, PTH, 10 to 65 pg/ml, alkaline phosphatase, 44 to 147 IU/L, and creatinine, 0.6 to 1.3 mg/dl. In patients on glucocorticoids, also measure urinary calcium excretion, 24-hour, 100 to 300 milligrams. Sensitivity of the laboratory panel for secondary osteoporosis is almost equal to 85%, specificity is almost equal to 70%. 3. Imaging. Perform DEXA of the lumbar spine, L1 L4, and total hip/femoral neck. The T-score is calculated as patient BMD, young adult mean BMD/young adult SD. A T-score less than or equal to 2.5 defines osteoporosis, minus 2.5 T-score 1.0 defines osteopenia. The precision error, coefficient of variation, for modern DEXA machines is less than or equal to 1% at the femoral neck. For FRAX scoring, input age, sex, weight, height, previous fracture, parent hip fracture, smoking status, glucocorticoid dose, rheumatoid arthritis, secondary osteoporosis, alcohol intake, and femoral neck BMD, or leave blank if unavailable. The algorithm yields a 10-year probability for major osteoporotic fracture and hip fracture. 5. Differential diagnosis. Distinguish osteoporosis from osteomalacia, low 25 OH vitamin D less than 20 nanograms per milliliter, elevated alkaline phosphatase, low BMD with normal T-score, Paget disease, elevated alkaline phosphatase 2 times ULN, mosaic bone pattern on radiograph, and metastatic disease, lytic lesions, elevated tumor markers. Key points: vertebral fracture assessment, VFA. Lateral DEXA VFA detects greater than or equal to 80% of grade greater than or equal to 2 vertebral fractures identified on conventional radiographs, with a radiation dose less than 0.1 msv. Quantitative CT, QCT, provides volumetric BMD in mg/cm superscript 3. A trabecular BMD less than 80 mg per cubic centimeter at the lumbar spine corresponds to a T-score is almost equal to 2.5. QCT is reserved for patients with degenera. References. 1. Kadawada et al. Prevalence and predictors of osteoporosis/BMD below expected range for age in pheochromocytoma/paraganglioma and BMD, TBS change postoperatively, a prospective cohort study. Indian Journal of Endocrinology and Metabolism. 2023, 27, 187-90. PMID, 372152262, https://pubmed.ncbi.nlm.nih.gov/372152262. DOI 10.4103/IGEM.322_22. 2. Ceccarelli F. et al. Fragility fractures in lupus patients, associated factors and comparison of 4 fracture risk assessment tools. Lupus. 2023, 32, 11-1320-1327. PMID, 37698854, https://pubmed.ncbi.nlm.nih.gov/376988854. DOI 10.1177/09612033231202702701. 3. Martins P. et al. Heart failure is associated with accelerated age-related metabolic bone disease. Acta Cardiologica. 2021, 76, 7718-726. PMID, 32498656, https://pubmed.ncbi.nlm.nih.gov/324986656. DOI 10.1080/0001538.2020.1771885. 4. Mock CC et al. Estimation of fracture risk by the FRAX tool in patients with systemic lupus erythematosus, a 10-year longitudinal validation study. Therapeutic advances in musculoskeletal disease. 2022, 14:1759720x2210744451. PMID 351544418. https://pubmed.ncbi.nlm.nih.gov/351544418. doi 10.1177/1759720x2210744451. 5. Ping Q et al. Retinal biological age correlates with bone mineral density and fracture risk score and predicts incident osteoporosis. PLOS Digital Health. 2026, 5E0001360. PMID 421335570. https://pubmed.ncbi.nlm.nih.gov/421335570. DOI 10.1371/journal.dig.0001360. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.